Hello, everyone. Good afternoon. My name is Dr. Adelaide Oponjamna. I am the moderator for this session today. Welcome, everyone, to Can Support Network of Ghana Educational Session of the Month. Our organization is a nonprofit organization born out of compassion to care and support persons affected by cancer. Our goal is to help affected individuals and families through their cancer journey, and we believe that no one should go through this journey alone. Part of our mission is to educate people, and this month we are going to be talking about cervical cancer. And so we have, and the goal of the panel discussion is to identify causes, symptoms, talk about treatment. We're going to discuss risk reduction as well as prevention. The hour session that we have is going to be, we have esteemed speakers today that I'm going to introduce in a few minutes, and then I'm going to ask a few questions. They're going to be able to respond to those questions, and as they do, we please encourage you to put your questions in the chat. In the chat, any question that comes to mind, please put that in the chat. And as we're going through these questions, I would bring that to the attention of the panel and they would respond to those questions for you. So please feel free to do so. As you enter, please feel free to mute yourself so that we can have a seamless session today. Now I'm going to go ahead and introduce Dr. Juliet Apia-Kwanzaa, who is the founder of Cancer Support Network. She's a hematologist and oncologist, and she will be one of the members who will be talking about our discussion today. Now, Dr. Apia, can you please wave so people can see who you are?
Hi, okay, hi everybody.
Yeah. We also have Dr. Chiza Chendu. Can you wait for us? She is born in Nigeria and raised in Nigeria, and did a medical school and PhD in Baylor College. She's a radiation oncologist. This is her second time joining us, and we're really happy that you can join us today and educate us today. So we're really looking forward to you educating us today. We have Dr. Karen Prempe, Ajiman Prempe, who is joining us for the first time. She went to Kwame Nkrumah University of Ghana. She's also have a master's degree in global public health from Queen's Mary University in London, and a medical doctor in Ghana. She's the founder of Cervical Ghana Foundation, and she really has passion in helping and educating and treating cervical cancer in Ghana. So we're really pleased to have her join us with this educational session to really tell us what goes on in Ghana, some of the things that she's seeing in Ghana, and to be really add value to our educational session today. And we have finally Dr. Cecilia Banger, who is a board certified OBGYN, who was born in Ghana and did her medical school in University of Oklahoma and residency in UMDNJ in New Jersey, and is currently practicing in Greensboro, North Carolina. I want to welcome all of our panel today. We are really thankful that you have joined us today. And I'm going to start this off by asking Dr. Kwanzaa to tell us about what is cancer and what is cervical cancer.
All right, thank you everybody for being here. I'm so glad I can join this panel discussion today. So basically, cancer is a disease or a group of disease that involve abnormal growth of cells. So depending on where this abnormal growth of cells is happening determines the name of that cancer. So for instance, today we are going to be talking about cervical cancer, which is basically, and I will leave this to the OBGYN to kind of give us an overview of what a cervix look like, but it's what connects the vagina to the womb. And based on the abnormal growth in this cervix, we call it cervical cancer. So basically any cells that goes uncontrolled, grow uncontrollably is called cancer.
Thank you so much, Dr. Pierre. Now we're going to go on to the next question, and I'm going to ask Dr. Banga and Dr. Premper to weigh in on it. And that is, what is the incidence and risk factors of cervical cancer? And then Dr. Banga, you can start, and then Dr. Premper can weigh in as well.
Okay. Thank you for inviting me to be a part of this panel. I'm very happy to be here. So, risk factors for cervical cancer goes back to the type of exposure that somebody has. So the main risk factor is exposure to a virus called the human papillomavirus, HPV virus. HPV virus has a very broad range of viruses that are encompassed in that category. There are some that do eventually cause changes that lead to cancer, and then there are some that don't. Some that make no changes at all, some that cause what we call benign lesions, meaning they cause growth of cells that may be unseemly to view visually, but they don't necessarily cause cancer. And then there's some types that actually eventually cause cancer. The three main types of HPV that do tend to cause cancer are the 16, 18, and 45 strands. And you're mostly exposed to these strands through exposure to bodily fluids, and mostly involved in sexual activity. So either exposure through vaginal to penile fluids, oral to vaginal fluids, oral to penile fluids. And that's the main way that most people get exposed to HPV, which can cause changes that eventually lead to cervical cancer. You're also at risk if you are a smoker, because it does lower your immune system. So it does put you at slightly higher risk for exposure. And we'll probably delve into this a little later, but if you have any other sexually transmitted infections, specifically HIV, that can also make you at higher risk for cervical cancer.
Okay, thank you for having me on here. It's as if I've been thrown into like shacks here, so I'm going to try my best. So talking about the risk factors, I love to group it into possible contributors. So for instance, when I talk about women in our part of the world, okay? So when I say our part of the world, I specifically take it to Ghana, Nigeria, West Africa, Africa, before I even extend it to the whole world, I mean, globally. I look at it in a global perspective. Now, let's identify Ghana or Nigeria. Most of our women, even though are hardworking, there's a greater proportion of them that depend solely on the male for financial support. And so that groups them into a minority group of low socioeconomic status. Why do I bring up this factor? That's because getting screened has to be paid for, unlike people who live in the UK or possibly in the US, where it's part of your health insurance. That notwithstanding, even in the US, you're still paying for it, right? Even though it's part of your health insurance. So now back to home, Ghana, Nigeria, Africa, this woman doesn't actually have money enough to cater for her health, talk less of actually just paying for getting screened. So this puts the person in the bottom of the bowl, basically, putting them on a higher risk because they're not going to get screened. They don't have a say as to what kind of sexual practice the man is supposed to practice here. So that leads us to multiple sexual partners. Now, when a man or a woman, let me be, general, practice unsafe sex, that's unprotected sex with multiple partners, this person is exposing themselves to the HPV virus, which is the primary cause of most cell changes that lead to cervical cancer here. And so it's as though you are not intentionally, but then getting exposed. So these are like possible contributors that increase your risk for cervical cancer. Like she mentioned earlier, she said smoking. We are lucky because when you look at the research, the data, the proportion of women who actually smoke in Ghana or Nigeria Not as high as the Western world. So globally, yes, smoking is a contributor, a higher risk. It puts them in a higher risk. But then in our part of the world, clearly that's at the bottom of the list. The human immunodeficiency virus actually predisposes you to higher risk of cervical cancer or the cell change as well, because already your immunity is low, and that contributes to faster cell change if there's any injury at the cervix. Now, chlamydia infection, long-term use of birth control pills have been seen to expose women to this as well. Now, the most one that I speak to people about, that I notice Ghanaian people or even in Nigeria do not know, let me speak for Ghana specifically, is that they do not know that a family history of any form of cancer, being it your father or your mother, predisposes you to having cervical cancer or any other form of cancer. And your mother, or a maternal lineage having a previous history of cervical cancer itself makes you at a higher risk of getting cervical cancer as well. Multiparity, that's having so many children without any form of ideal separation, with too many, different partners, takes us to the top of the list that I spoke about, i.e. even linking it to having multiple sexual partners, and we not as women being empowered enough to have a say as to who we have our children with, who we have sex with, how we pay for our health bills and whatnot. And so, there are quite few that are coming up whilst people are doing research, like certain diets are coming up as well. These are a few contributors to increasing your risk of getting cervical cancer that I can come up with.
Thank you.
Let me just jump in here for a little bit, if you don't mind.
Thank you. Yes.
I think you guys have all made excellent points. I need to add to for the audience that the human papillomavirus is ubiquitous, and that means that in the course of your lifetime, about probably 99% of us will at some point have the human papillomavirus infection. So having the human papillomavirus infection does not mean that you have necessarily voluntarily engaged in any high risk behavior, but because of the nature of the game, really, and the speaker right before me really highlighted that that sometimes you don't have a say in who comes into your life and how it impacts you. At some point, 9 out of 10 of us in this place, or even more, or even maybe 100% of us at some point been exposed to the virus. Now, why have we not all had cervical cancer? Because the vast majority of us have healthy immune systems that can clear the virus without it developing into cancer. And I'm sure we'll go into this in detail. But the main thing is to know that at some point, everybody will get infected with HPV, and you just clear it without you even knowing. And this is why screening is important, because there's really no way of knowing at what point this your body doesn't clear it and decides to progress into more serious disease.
Thank you,
Abby,
Chiza. You have actually moved right
just
to
to
my
add
second
one more
question.
risk factor, because Dr. Chisa has mentioned about, we being able to, we have good immune systems. So people who are immunosuppressed are usually at risk for this cancer in particular. And I think Dr. Prempe had mentioned about HIV, but there are some people that are on long-term steroids, some people that are on immunosuppressive for rheumatological disorders and some of these inflammatory disorders that put them at risk as well for having cervical cancer. So especially in these patients, we recommend that you have to be on top of getting your screens done, talking to your doctors about when it's appropriate to get screened. And you may be screened more than the general population just because you're on long-term immunosuppressive.
Thank you so much. So I guess we've all really, ushered into the next set of questions, which is what is HPV screening? And if Dr. Benga, you can start HPV screening and what is a pap smear? And part of this set of questions is the HPV vaccination, and in terms of ages in which these vaccinations are given and the safety that comes with the vaccination, because as part of people want to know about the screening and they hear about these HPV vaccination. I get a little call. Should I give my daughter? Should I allow my daughter to take it? Should my son get the vaccination to prevent cervical cancer for my daughter? So please talk about the Pap smear and as well as the HPV screening. And Dr. Premper, you can weigh in as to what how often women in Ghana are getting screened as well, and if there is any vaccination protocol in Ghana as well, we would like to hear from you, Dr. Premper. Thank you.
Okay, so a little later, I'll try and see if I'm able to show a little picture about what the cervix actually looks like, because I like to always start my descriptions with defining the anatomy. That tends to sometimes be just the basis of explaining to people what we're actually doing. So I'm going to attempt. I hope I don't get a glare back from the camera, but I've experimented with different ways of showing this, and sometimes it works, sometimes it doesn't. So this is a great picture that shows what our vagina, uterus, and ovaries and everything looks like. And excuse the pen marks, because I've used this a few times and I can't get the pen marks off. But this is your uterus. This is the neck of your uterus, is what I call it. And that's what your cervix is. This is your vagina here. So when we talk about doing a pap smear, what we're doing is, again, we're screening to see if you've had exposure to HPV and if that exposure has caused any changes to your cervix that could eventually lead to cervical cancer. So there's several different layers here, and I love how that was explained before. Just because you have exposure to HPV does not mean that you're inevitably going to get cancer. When we do a pap, perfect, thank you. When we do a pap smear, which is the means by which we screen to see if there are abnormal cells on the cervix, what we do is we put an instrument into the vagina so that we can see the cervix. That instrument is called a speculum. There are several different kinds of speculums. There are some that are plastic, there's some that are metal. Some people seem to have a preference for one over the other. It really doesn't matter. All it does is allow us to visualize the cervix. When we visualize the cervix, which usually looks like a donut, hence the donut in that picture, what we do then is we take little tools to scrape some of the cells of the cervix. Now that sounds a little painful to say it that way, but it really is not that painful. It's maybe uncomfortable initially because of something touching your cervix, and it's probably more of a pressure sensation than a pain sensation. So we usually take the first tool that most people use is called a spatula. And depending on the type of screening that you're doing, most people will use a spatula to scrape gently some of the cells of the cervix, and then they'll use a brush to put inside the hole of the cervix to screen to get some of the cells from inside there as well. It's a quick procedure. It probably takes less than 2 minutes to actually do. And just by sending the sample of those cells off to a pathologist, they can look at that to see if there are normal cells that we're showing on the cervix, if there are cells that are showing any kind of changes, if those are changes we should be worried about, if those are changes we should not be worried about. And they can actually drill down a little further to say what specific kind of abnormal changes there are, if there are those as well. So that's it for the pap smear per se. In terms of some preventative things we can do to try to decrease our risk of exposure, the one specifically I'll talk about is the vaccination. This is the era of vaccination. That word seems to be very popular lately. So there is a vaccination called the Gardasil vaccination that is available, at least here in the United States. And I love that we have a panelist that is here to tell us what's going on in, the continent that we're all originally from. So the Gardasil vaccination was developed over 20 years ago here in the United States, and it screens specific. It is aimed to help prevent exposure. Well, let me not say prevent. It's helped to protect you from exposure to those 3 strains of HPV that I spoke about before, 16, 18, 45. So the goal of that vaccination is for you to get it before you are exposed to those viruses, so that it can help to protect you. If you have already been exposed to those viruses, sometimes it's not as beneficial. It is designed specifically for ages 11 through 26, but that can be expanded up until age 45 as well. It was originally designed for girls, but it is applicable for males as well. And it's a series, it was initially a series of 3, and I believe now it's a series of 4 shots that you get at certain intervals. I hope that was explanatory enough.
It was. Thank you so much. Dr. Prempa, if you can weigh in here. I think you mute.
I started smiling when you talked about the screening program in existence in Ghana. And simple put, we don't have a screening program in Ghana. It's that simple. There isn't any, unfortunately.
Which is sad, but
Very
true.
And we are reporting over 3,000 cases, incidents in the terminal stage yearly, with 2,000 out of that dying. So my story is sad, but I put a smile on your face. Today, every January, people talk about cervical cancer. So that wasn't the story about 6 years ago. My first little research was in Bator, where the ladies, after meeting them, had to ask them about cervical cancer, and I've still got data on that. And most of the women, 64% out of the women in the clinic had never heard about cervical cancer in their lives. But then there was a cervical cancer center in Bator. Yeah. So not only was it a cohort in Ghana, not only were they women in their reproductive age sexually active, they were somewhat educated, because when you find yourself in the health facility working, we assume that there's somewhat education. And 64% out of these women had never heard about cervical cancer. So today, the reason why I'm telling you this is because I am happy that every January we do hear about cervical cancer in Ghana. It's become a norm. And so I like not to be too negative. I'm a bit, excited here. Now, most of the cases that we get are opportunistic screening. This is because maybe the woman is, presented with unexplained uterine bleeding, some vaginal discharge that we in a form of diagnostic, workup, then we chance upon it that, let's just do a pap smear and see. It's all part of the workup that we do for these women. And then, 3,000 annually get caught as cervical cancer. Now, you will think that when an incidence rate is addressed, we should have a good story because the disease has been identified, right? No. 2,000 out of the more than 3,000 women that I identified are lost in mortality because most of these women do not know that whatever they are experiencing is cervical cancer. They don't even know that it's preventable. So by the time we get to these women or diagnose these women, they are already in their terminal stages. And sincerely, oncology is very expensive in Ghana. And this takes me back to us being in the bottom as low socioeconomic status back at home. Don't look too gloomy, no. Please, I know the story is sad, but then today, people are being screened for about, I mean, it costs about 200 cedis to 170 cedis. This is too expensive for a woman in Ghana. Way too expensive. This is, I mean, for the sake of those of you in the US, you're paying more than $30 to get screened. And trust me, the average woman can't just come up with this amount of money. That's where organizations come in, you know, they screen for, you know, a group, like you get a group of professional women who will say, you know what, we're going to raise money and, you know, screen about 1,000 women in this area. As a public health person, I feel like we are cherry picking. And I would hope that we all, I mean, for how long am I going to keep taking money from each other, you know, raise money, go and screen up someone because of I mean, it's just not sustainable. That's the word. And so whenever I have a platform to meet women like you, I plead with you to speak about this so that we can somewhat have a program, because some women will get screened every 2 years, some women get screened every 1 year. That's because it's an opportunistic screening. We would love to have a national program where every woman is scheduled or is invited to have a screening. It's either being HPV, you know, testing combined with the cervical cancer screening. That's if you are not sexually active or, you know, not in the high risk group, or get invited to get a pap smear when you found yourself in the high risk group. We don't have a program at the moment, but then I advise women to do it every 2 years. In some areas where I feel like the financial status of the woman is a bit, you know, not favorable, then I advise that we do it every 3 years. And so we're getting somewhere, because I quite remember a year ago, I saw the Vice President, Mrs. Baumia, speak on a platform about cervical cancer, which was a good thing. But then this year, we are in a pandemic. So people are asking me, what do we do about cervical cancer in this pandemic? And I say that, you know what, let's still visit our clinics, let's still visit our healthcare workers and request for our screening to keep going on, so that we can at least have a pre-existing program that finally, when the government buys into our idea of having like a structured, you know, screening program, it wouldn't be so difficult to have to go back to the drawing board to start something. It means there's something already in existence. I'm sorry to bore you so much about my
Well, no, not at all. One statistic that I found when I first started talking about this was that alarmed me was that I think I looked at the WHO statistics for countries that had high risk of cervical cancer, and out of the top 40, 35 out of the 40 were African countries. That was very, very saddening to me. I think it's imperative that there's a national program established, and in any way means that I can speak on about it, I'm more than happy to. Now, I do know that other countries like India have a very high rate of cervical cancer as well. And it probably goes to the same factors that are affecting our continent as well. In terms of the timing of the screening, the way we offer it here in the United States is we do recommend, it's gone through a series of changes over the years. It used to be we started screening everybody at age 18, and then you got a screening every year for the rest of your life. At some point, it was when you were first exposed sexually. The current guidelines are for you to start getting screened at age 21. From age 21 through age 29, we screen every 3 years. Now, some populations of people who are at higher risk because of exposure, either through their professions, or exposure, there is leeway to go ahead and screen a little more frequently. Healthcare has to be individualized sometimes to a certain degree. We're not robots, we're not automatic. So that's what I love about my profession, is we can tailor things. But the guidelines currently are screening every 3 years from age 21 to 29, and starting from age 30 through age 65. If you do just the pap smear, like I described, where we take the sample of the cells and the brush sample, and we send it off just for assessment of cells, then it's still every 3 years. However, from age 30, we can also screen specifically for HPV. And if we screen specifically for HPV and that comes back negative, along with the sample of cells coming back negative, if both are negative, then you can space out the screening to every 5 years. So even if you talk about the financial aspect of things of that nature in Ghana, 100 CDs, 100 to 200 CDs over the course of 5 years for women still in reproductive age, over age 30, would be something that maybe can be more feasible for a lot more people. It's such a simple test that can catch things at such an early stage and be preventable, rather than us waiting until folks are, actually have cancer. So that would be a great initiative if something like that could be started.
Thank you so much. So
Um,
we're
I-
going
can I-
to see. Yes,
Oh,
go
I think
ahead.
Krista wants to-
I'm sorry, let me add that in places like Ghana or Nigeria, where access to screening is not readily available, we can actually employ the most recent guidelines from the American Cancer Society, which actually states that we can delay screening until age 25. Now, that's not always ideal, because we want to try to catch things as quickly or as early as possible. But in situations where it's not easily accessible, we can start screening at age 25. And the screening guidelines from the American Cancer Society actually indicates that we can do screening with HPV testing every 5 years. So being exposed to HPV, it takes time for the transformation to occur into cancer. So these kinds of buys us time. Now, it doesn't mean that, I think my point is that we can take the stress or the strain of our lack of resources by, adopting a workable guideline that helps a lot of our patients. Instead of, the pressure of trying to screen every 2 or 3 years, it's appropriate to screen every 5 years with HPV testing, so long as these people are going to follow up and get appropriate care.
Yes, the UK, I believe, starts at 25 as well. I know that it has been a slow adoption by ACOG and ACOG here in the United States for the age 25, but I do know, the American Cancer Society did recommend age 25 as a recommendation, and that is what they do in the United Kingdom.
Thank you. I think there were a question that Dr. Cheeser already answered for us, which is they're asking whether men can have a human papillomavirus and transfer it to their counterparts, and she did answer that in the chat. So thank you so much, Dr. Cheeser. There is a question that somebody just asked us, seeing that women in Ghana don't have much of a say as to when it comes to sexual activities, have there been any programs addressing men when it comes to this? I would ask if Dr. Premper can address this. I don't know if there's any programs I think that addresses this with men, but this is part of the educational thing, that we're not only educating women about the impact of cervical cancer and screening and things that lead to it, but also educating our men as well. But I'm not sure if there's any program, if anybody can comment on that question, if there are any programs addressing this with men about getting screened and.
Okay, thank you. Thank you so much. In our own little way, we have to go around, it's called an education, inclusive education. So I'm just not going around educating the women about cervical cancer, but then I'm using the opportunity to educate the men about the human papillomavirus, having the possibility of also causing something called the penile warts, and, you know, in total, the oral cancers and whatnot. When you're able to explain to them that there's something that is going to happen to the men if they don't actually pay attention to the human papillomavirus, then they listen to you. Because the moment you keep talking about cervical cancer, they start going like, okay, it's a woman's disease. So why do I have to pay attention to it? So when you include them in the education, where you're pointing that if you pay attention to the human papillomavirus, it's very important, because there is a chance that a human papillomavirus infection can lead to penile warts. Then they listen to you. And then when you're able to catch their attention and let them know that they could be carriers of the human papillomavirus and transfer it to us, the women, which may lead to cell change that may lead to cervical cancer, then we're getting somewhere. So I try as much as possible to encourage organizations that I teach. So I have a teach the teacher program that I do. And so whenever I meet people, I do tell them that whenever you're educating people, I mean, a cohort about cervical cancer or human papillomavirus, do include the men and try and point out that, yes, they do pay, they do, you know, take part in transferring the human papillomavirus. That is not necessarily to say that that is causing cervical cancer, but that will lead, that's the primary cause of cervical cancer in us. So we try to add them, but then you know how it's difficult to get the men to understand, but we're getting somewhere. Men are interested. I've got the Rotary Club. I mean, I've educated quite a few groups that include men and even just men groups about cervical cancer. So it's positive. Like I said, the story is not so gloomy and dark. It's we're getting somewhere in Ghana. And
Thank you. Thank you so much. So we're gonna move on to pre-cancer diagnosis and some of the symptoms that when a woman begins to experience, should take that seriously. So I'm throwing this to the panel to discuss some of the early symptoms as well as some of the late symptoms of cervical cancer.
so before we start, I just wanted to point that I remember early on in the discussion, we did mention that the pre-malignant stage is somewhat benign. So there's no symptoms, whatever. The good thing about cervical cancer amongst most cancers, or if not all cancers, is that there's a pre-malignant stage that is preventable. So every time I talk about cervical cancer, I say that there's something special about cervical cancer. It's preventable. So you can prevent the cancer from happening if you get screened early enough. Even before the screening, if you get screened for human papillomavirus, which doesn't mean the human papillomavirus is going to cause cervical cancer, but then by catching the fact that getting diagnosed or tested positive for human papillomavirus, you are able to address the issue so that it doesn't lead to the cervical cancer. I'm saying this to lead to the fact that the stages or symptoms of cervical cancer may be asymptomatic. You just would not show any sign. But then if we were to do a pap smear, we could see some cell, changes, a dysplasia here and there, which is not necessarily cancer yet. So that's when we do the cryotherapy, when we do the biopsy, and then we take in, something can be done before we get to the cancer stage. That's what I wanted to say before we start. Sorry.
So in my practice, I see a lot of cervical cancer patients, and the vast majority are in their early to mid 40s. And most of them present with vaginal bleeding. And as you can imagine, this can be a big stigma in our culture. Imagine if a woman was having just nonstop vaginal bleeding. Even from biblical time, that has been an issue. So nothing has changed with our culture. But that's the main thing that a lot of people show up with. Irregular bleeding, bleeding when it's, you know, off cycle, just nonstop, sometimes pelvic pain. Also, you know, when you bleed a lot, sometimes patients have symptoms of anemia. So just feeling really tired, your heart racing fast, and this can lead to heart problems if it's not caught on time. And the longer you go with these symptoms, you get more progression of disease. And depending on how the disease invades into neighboring normal structures, you can have obstruction of your bowels or rectal passage, and that can cause a lot of problems. So depending on what stage the cancer is found at, you can have different symptoms. So vaginal bleeding is the main thing. There's pelvic pain, sometimes weight loss, back pain. And I've actually, had patients come with discharge, foul smelling discharge. And in much later stages, sometimes patients have a lump in their neck, usually on the left side. It's usually caused by an enlarged supraclavicular lymph node, and that's usually in the more advanced stages. But it's very important to be caught early, especially in our homeland, because as one of the speakers spoke earlier, oncologic treatment is very expensive. And if found early, a lot of these cancers can be treated surgically, and that would be all you need. But many times when these patients come to me as a radiation oncologist, they are usually in a more locally advanced or advanced stage, requiring multidisciplinary treatment, requiring chemo, radiation, brachytherapy, all these, really expensive and involved treatments that are not necessarily easily accessible in places like Ghana or in Nigeria, as a matter of fact. So I think even if you missed the boat and did not get found or get discovered in the pre-cancer phases, there is still a chance for cure in the early phases. Stage 1 or even stage 2 can be treated surgically. Once we start getting to stage 3, stage 4, then you're going to need more advanced treatments that are not even available. So I think it's in all of our best interest to make sure that we and our families and our patients have access to simple, much easier, even though you mentioned the cost of pap smear and screening, it's the cost of getting chemo and radiation far outweighs that cost. And if you think about it, if you're getting pap smear and HPV testing every 5 years to prevent something that can save you, hundreds of thousands of millions of cities or dollars or whatever currency you're using, it's definitely worth it. So I would not, I'm a radiation oncologist and I treat patients with cervical cancer. And sometimes even in the process, I look at what we do, especially during brachytherapy, and I would not wish that on my worst enemy. It's not an easy thing to go through. So I really, encourage people to, be very vocal, and that's why we do this. And we, invite our friends and family to listen, because it's very important. We have 600,000 people diagnosed with cervical cancer every year, and the vast majority are in Africa. So we have roughly maybe 20,000 people in America, or less actually, like 15,000 people being diagnosed in America every year, and the mortality rate here is about 30%. So it's still high, but the numbers are flipped in Africa. So if we're diagnosing 600,000 people every year, and only 20,000 or less are in a big nation like the United States, where the heck are the rest of them? So we're getting this burden, this disease burden in the developing world, primarily in our home continent. And it's something that is so easily preventable. So that's just my input on that.
And just to add to, the statistics, Basically, cervical cancer used to be the #1 cause of cancer death in the US some years ago until we started screening. So screening is very important. And the statistics, I think in 2020, 12,000 people were diagnosed with cervical cancer. And out of the 12,000, I think 3,000 of them died from their disease. So just as Dr. Ichendu said, where is the rest of these people? Majority of them are in Africa. So we need to have a way of getting screening for these patients. If United States, #1 cause of cancer death in women can be reduced to, I think it's number 6 or 7 or 10, on the list now for cancers that kill women here in the US. We all need to put our voice together to help people back home, and not just Ghana, Africa in general, Nigeria, wherever. Whatever little that we all can do. This is why we do these programs, to bring the awareness, and all our voice can go a long way.
If I could just add something little, going back to the original question being the symptoms. So if we look back at what the cervix looks like, so I think Dr. Ichendu talked about the different stages that she sees sometimes. So stage 1 is usually just limited to, or pre-cancer cells, and stage 1 are usually limited to around the cervix area. So typically for me, in my patients, the symptoms that I will see they range from no symptoms at all, like was said before, to a change in vaginal discharge. And I love talking about this because I like for women to know what their vaginas look, feel, and sound like, basically, because if you treat that area like a mysterious area that you never look at, you wash it in the dark, you never visualize it, then you don't know when there are changes to it. So if you know what your normal vaginal discharge looks like, smells like, then when there's any kind of change, it's easier for you to pick up on that. So vaginal discharge is sometimes some of the symptoms that I'll see initially: change in smell. It's specifically with bleeding, bleeding after sex. So we call that postcoital bleeding, might be some of the initial changes. As it starts to cause cervical cancer and the cancer starts rising, so your staging changes. There's 4 stages to cervical cancer. There's stage 1, 2, 3, and 4. So stage 1, like I said, will usually be limited to the cervix area. Stage 2 comes down to the top part of the vagina and the area surrounding the uterus. Stage 3 will start to go a little further out. So you're going into like the lower part of the vagina, the pelvic wall surrounding the uterus and the vagina, and then into the lymph nodes. Lymph nodes are we have our blood vessel system and we have our lymph system. The lymph system carries all the fighting organisms of the body. So if they're inflamed and engaged to fight, sometimes you find little lumps in the groin area, which is the area surrounding the uterus and the vagina. And then, so you might find little lumps there. If we do, then sometimes that's indicative of stage 3. And then of course, stage 4 is when it spreads a little further up. And, as they mentioned, you can sometimes even find lymph nodes as high up as in your neck. So just wanted to give a little pictorial on that as well.
Thank you so much. Everybody's going just the way things are planned. So it's really beautiful. Thank you so much, Dr. Banger. So Dr. Pierre, can you please tell us about the types of cervical cancer that are there?
All right. So as everybody has already said, the main type of cervical cancer is squamous cell, which is because the main risk factor for cervical cancer is HPV virus, and it causes the squamous cell type of cervical cancer. Not to say that you cannot have other cancers there. They are very minimal. You can have what we call adenocarcinoma, which is a different cell type. It's a very small percentage that can happen there. You can also have melanoma, mucosa type of melanoma. So melanoma is usually a skin cancer that can metastasize or spread to other parts of your body. But we have a specific type of it called mucosal melanoma, which can affect anywhere from your mouth to your anus. And that can happen in the cervix as well. What else? I think those are the main ones. I don't know if Dr. Banga has other ones that she can attest to, but adenocarcinoma, squamous cell by far, the most common one, adenocarcinoma and mucosal melanoma can happen in the cervix as well.
Thank you. So now we're going to move on to treatment of cervical cancer. So Dr. Banga, if you can start us off with some of the surgical options for treatment of cervical cancer, that would be great.
Okay, this might be more of Dr. Echendu's wheelhouse. But yes, so treatment usually will range from the staging of the disease. So if we find precancer cells, or sometimes we can do something as simple as a biopsy, which means we take a bite of a sample from the cervix. We do that a lot of times to get the actual diagnosis, but it can also be therapeutic. So taking that bite out, we send it to the pathologist. They can tell us, yes, this was a precancer lesion. But doing that may be enough to just take that tiny little portion out of the cervix, and that could reduce the amount of virus there so your body can fight off the rest of it, right? So that's one particular initial stage that we can do. Sometimes we need to take something more than just a bite of the cervix. Sometimes we need to take more of a wedged portion out. There's a procedure called a LEAP procedure, where we will take a heated coil and sort of shave off the top layer of the cervix off, and that can take all the precancer cells away. So that's one option. If we're taking more of wedged portions out, those are called cold knife cones or conization procedures that we can do. And these are usually quite successful with precancer lesions or early stage lesions. As we start to go a lot further, we may have to look at hysterectomies. And some nuances that come into play here are whether this is found in a woman who has already completed her childbearing. Because if she has, she might be a little more inclined to want to have everything taken out. If she hasn't and she wants to preserve her fertility, then we have to get a little more creative with how we go ahead and carve out the abnormal cells. So it can be something as simple as a biopsy. It could be a LEAP procedure where we shave off the top surface layer. It could be a conization procedure. It could be a hysterectomy. Depending on what we do there, and what the diagnosis tends to be, if it's just squamous cell cancer, if it's adenocarcinoma, if it's a mucosal cancer, and how systemic it has gotten, we may need to consider things like chemo and radiation as well. And that's where I tend to end my treatment and hand off to further specialists.
Okay, Dr. Chindu, we move on to you. So tell us about radiation therapy and some of the chemotherapies involved in treatment of cervical cancer.
So most of the patients I see are usually stage 2 or greater, stage 2B or greater. And those patients are getting a combination of chemotherapy and radiation. The chemotherapy is usually given by the medical oncologist or the gynecologic oncologist, and they get a weekly infusion of chemo. And then they get radiation every day, Monday through Friday, for about 5 weeks. So now, every day you come for a treatment, it lasts about 20 to 30 minutes. It's not a long treatment. It's kind of like getting an x-ray, it's like laying on a table and having, the machine go around you. It's not really a painful procedure at all. It's not a debilitating procedure, at least the beginning part, the external beam. So it's called external beam radiation therapy, where the radiation comes from an external source. So you lay on the table for 20 minutes and you get off the table, and most patients do just fine. So some of the side effects patients have with treatments is sometimes they get low-grade nausea, especially with a combination of chemo, some diarrhea, some urinary frequency, because when we treat the pelvis, whatever is in the pelvic area will probably get some radiation and get irritated. And so your bladder is right there. And so if it gets irritated from radiation, patients feel burning with urination or frequency with urination. So now, once the external beam part of the radiation is completed, we do something called brachytherapy, oftentimes for the patients. And brachytherapy simply means putting the radiation right next to the cancer. And this is a very important part of treating many locally advanced or late stage cancers. And so this oftentimes requires taking the patients to the operating room under anesthesia. We do an examination to see whatever disease is left behind after the 5 weeks of radiation. So we do the 5 weeks of radiation with chemo. We examine the patient under anesthesia and see what's left behind. And then we insert radiation basically right next to the residual tumor. And depending on what system is available, the patient can be in the hospital for about 2 days. And then we have to get them back again 2 weeks after that and do the procedure again. So under anesthesia, do the same procedure again. So we try to finish treatment within 8 weeks. So from start to finish, we try to get everything done within 8 weeks, because we've shown, there's studies that have shown that if the treatment time is extended more than that, the results are really not as favorable. So, you know, it's a race against time from when we start treating, and, you know, we have to get all our ducks in a row. So it's not, like I said, the first part is really not all that involved. It just requires commitment from the patient to come every day. But the second part, you know, is quite involved. It requires, you know, having devices being placed inside of you, and, you know, requiring hospitalization and being away from people for a couple of days while the radiation source is inside the cancer. And I think that's kind of the part that really bugs me with the whole treatment process, but it is very necessary part of getting treated. But, you know, doing the process, doing the procedures and seeing the disease and seeing, you know, having to dilate the cervix, you know, it's kind of, it feels a little barbaric sometimes, but it's something that has to be done just to make sure that the patient gets the care they need.
Thank you so much. Dr. Pierre, can you move us to target agents and immunotherapy when it comes to surgical cancer treatment, please?
Right. So radiation is not without side effects, right? So we will want to avoid that if we can. And that's when the screening comes in. So by the time you get to me, the early stage ones that we come in, Dr. Ichendu had mentioned, we do the concurrent chemo radiation therapy, meaning you're getting chemotherapy and radiation all together. And some of the agents that we use for cervical cancer is very aggressive, because this cancer tend to be very tough to treat. And that's why radiation works so well for it. So once you are beyond curable or as being able to put you in remission, like, you know, limited, locally advanced, meaning like, you know, it's just within the pelvis, we can do that. But once it's beyond that, it's gone beyond the pelvic region. It's gone into your liver, it's gone into your lungs, or the lymph nodes up here in your neck region, or any other organ. I think sometimes if the bladder is involved, we can still call it locally advanced. There are extensive surgery that they can do for that. But if it moves beyond the pelvic region, then we're talking about systemic therapy. So up until 2014, we had just chemotherapy that we gave for systemic disease, which is disease that has spread beyond the pelvic region. And like I said, it's a platinum-based chemotherapy, so a lot of toxicity. Nowadays, I think in 2014, Avastin or bevacizumab, which is an anti-angiogenic medication. So like cancer cells are fed by blood vessels. New blood vessels are generated and they are fed by that to be able to grow. So this medication called Avastin was approved for this to kill this new growth of blood vessels so that we can kill the cancer. And that was shown to help with survival as well as like progression free, the time it takes the cancer to spread. So in 2014, Avastin was added to chemotherapy. And more recently, thank God, we have immunotherapy. And I say thank God we have immunotherapy because it's less toxic. And immunotherapy is basically therapies that use your own immune system, basically takes the gears off of your immune system so that you can use your own immune system to fight the cancer. They are all given IV, of course, even though it has less toxicity, it's not without toxicity. I've seen people have severe reactions to immunotherapy. So if we can avoid systemic therapy at all, we want to do that. And the only way to do that is to be up to date with our screenings. And, going back to the screening, let me just add this. Even here in the United States, there are some disparities. So screening is available for everybody. But what we have found is that in the African-American population, they don't go back after they are diagnosed. So in terms of getting care, post-care after diagnosis, and also even if they have intraepithelial lesions, so precancerous cells, majority of them don't tend to go back. So by the time they come back, their disease is advanced stage. So not just people back in Africa, but us here in the US as well, we should utilize what we have available to us, because you don't want to get chemotherapy, you don't want to get brachytherapy. I saw that during training, when I was training, and it is barbaric, and then even the standard beam radiation, you can have some proctitis and GI symptoms and stuff like that. So all these therapies are not without side effects. So the best way to avoid having to come to a medical oncologist like myself or going to a radiation oncologist like Dr. Ichendu is to stick with Dr. Banga and get your screening done, and Dr. Prempe, and get your screening done and get the disease taken care of in early stage.
Thank you so much. Is there anything like recurring disease, and after you've battled and you've treated cervical cancer, how often does it come back, and what treatments do they have to have?
I don't get to see a lot of recurrence of cervical cancer personally. Now, we mentioned before that abnormal cells can be present for a period of time. So I do frequently see people who have pap smears that will come back with some mild changes, and then they'll resolve, and then they may come back and resolve. That's not cervical cancer. That's abnormal changes to the cells of the cervix and maybe precancerous lesions. So those we can sometimes monitor for a bit, and they can sometimes improve and then worsen, improve and worsen. In terms of by the time it actually gets to cervical cancer, the efficacy of some of the treatments are really good. So a lot of times it's curative to take out the offending area, right? So if it's localized to the cervix and we carve it all out and we make sure that the margins of the areas that we carved out were clear, then the risk of recurrence are very low. When it gets to the point where you've got your medical oncologist and your radiation oncologist involved, as you heard from what they described, the treatment is quite aggressive. And unfortunately, if it doesn't work, then it usually leads to death, unfortunately, which is why we stress so much about the importance of prevention, because it takes such a long time from exposure to HPV, the type of HPV that would cause cervical cancer, the time from exposure of that to the point where you need those aggressive treatments. It's not a fast acting virus. It takes a long period of time. So if you're able to get in at some point to be seen or treated early enough, then it prevents you from getting there. But once you get there, typically the rates of recurrence are low, because then you're dead. I did want to say something else about the populations that we do see here in the United States that have high risk. Yes, our Black population is higher risk in terms of incidence and progression, but also I did my schooling in Oklahoma, and other marginalized communities that I'm seeing here in the United States are our Native American populations and even our immigrant populations. Now, I do accept that some of that is because patients don't go back for follow-up treatment, but I put the onus on a lot of my physicians in terms of explaining the severity and the preventative options available to patients. Sometimes some patients hear that and it scares them so much to hear that they may have some mild cervical changes or anything that could lead to any sort of cancer, and they get scared. And they focus instead on taking care of their families instead of taking care of themselves so they can take care of their families even better. So I put the onus on a lot of physicians in terms of explaining things in a culturally and coming down to the level of our patients if they're not able to understand us properly, getting the resources available for them so that they know how to follow up. The patients that I tend to see who have cervical cancer that has progressed more than the precancerous stages and whatnot are women who did not follow up for their PAPs after having their children born. One of the things that has been implemented that I think is very successful here in the United States is at prenatal visits, we do a pap smear if you meet the criteria for it. So pap smear screening at your pregnancy visits captures those women in those childbearing ages so that they don't fall through the cracks. And most women here will get some sort of care during their pregnancy. So that's a great time to go ahead and capture women there. But I put the onus on us, the generalists, to make sure that our patients are well informed and aware of resources that are available to them.
Thank you so much. Dr. Chizo just answered the questions that I was about to answer from the chat, so thank you so much. The other questions is when somebody gets a hysterectomy, for example, Dr. Branca, do they still have to get their pap smears done? And while you're answering that, what is the end age that we don't have to do pap smears anymore, and things like that?
Okay, so again, for here in the United States, the recommendation is once you get to age 65, if your last 3 PAPs were normal, you don't need to have a pap smear anymore after age 65. Now, there's of course some grumbling about that because it doesn't mean that life ends at age 65. Women over age 65 are sexually active and may have new partners as well. So again, we're not robots. There is some leeway there to tailor care to your patients, but in terms of the guidelines, it's age 65. Once you have a hysterectomy, depending on the reason why you had the hysterectomy, you may or may not need to continue having pap smears. If you had a hysterectomy for what we call benign reasons, so reasons not related to cancer, you had a hysterectomy because of fibroids, you had a hysterectomy because of scar tissue from previous surgeries causing pelvic pain, for things like endometriosis, for any reason other than, or your uterus is falling after having multiple children, so you've got prolapse. You know, if you had the hysterectomy for those kind of reasons, then, and your last few PAPs were normal, you don't need to have PAPs anymore, especially if your hysterectomy was a kind of hysterectomy that took out your uterus and your cervix. Sometimes you'll have a hysterectomy where we just take out the uterus and we leave the cervix, the neck is still there. If that cervix is still there and you have a history of abnormal PAPs, you need to continue having PAPs. If you had your hysterectomy done for cancer reasons, meaning cervical cancer, then you need to continue having PAPs for up to 20 years from when you had the surgery done.
About, is there a direct link between childbirth and cervical cancer, or can childbirth make a person more vulnerable?
Well, when we are pregnant, we do have a slightly lower immune response. So yes, there is the possibility that precancer cells or cervical cancer can progress during pregnancy. And I think that goes back to why we screen everybody during pregnancy as well. But in terms of childbirth specifically causing cervical cancer, short of the risk of exposure from multiple partners, I don't think that there's a specific correlation, and anyone can correct me if I'm wrong on that.
It's actually, and I think Dr. Prempe had mentioned it earlier, that multiple birth has been associated with having increased risk of having cervical cancer, because I think, just as you have spoken to, like, your immune system goes down, and like the fact that you're exposed to, like, you know, partners and things like that. But it is one of the listed risk factors. Multiparity is one of the listed risk factors.
There's a question for us. Can cancer in any part of the body also lead to cervical cancer?
I guess if you talk about that, also reducing your immune response, because if you have cancer, then your immune response would go down as well, then I can see that. I would be curious with that statistic about childbirth, multiparity related to increased risk of cervical cancer, and teasing out the cause of that. Is that in patients who had multiple partners in terms of the fathers of their children, or is that less so if they had a single partner? I can see for sure where the immune response going down in pregnancy recurrently and not getting interval treatment for abnormal pap smears can cause that to progress. But that's something that I think I'll have to look into some more.
I open this for the panel to give us their last few words. It being prevention, it being things that this people who have patiently waited to hear us answer their questions, what the takeaway is, so that when they leave the cervical cancer session, this is what they took away. So I'm opening this up for the panel to be able to give us their advice and their last minute recommendations.
Adi, before we go there, let me speak a little bit about the vaccine, because I think you had asked about, like, you know, side effect to the vaccine.
That was exactly the one thing that I wanted to address too.
Yeah,
So
I got the vaccine. I got the HPV vaccine before I turned 26. I was lucky to get it before I turned 26. And it's just like any other vaccine, you know, maybe, like, you know, the site of injection may hurt a little bit. I got the Gardasil vaccine, the 3 shots that were given, I think, 1 month, 2 months, and 6 months, or something like that was given. And I did not have any significant side effects. So just like you're getting your flu shots or all your immunizations, it's just like that. No significant side effect to that vaccine in particular. Of course, we do have the, like, you know, the odds that, like, you know, 1 or 2 out of the 100% may have some severe reaction to it because of the substance that is in it. But it's just like any ordinary vaccine, nothing really. So encourage your children to get it. Is that available in Ghana? That's my question to Dr. Prempe. Is the vaccine available in Ghana? You're muted.
Hi.
Yeah, is the vaccine available in Ghana?
Yes, it is. We have, but obviously private, not, the public sector. So you would have to request for it to be done for you, and then you keep visiting the health facility that you got it from. We haven't seen any reactions so far because I guess the number that is taking the HPV vaccine is not that many. However, because of public health reasons, we advise that you only give it to kids or male and females who have never had so male or female who are not sexually active. Because in our part of the world, because the kids are so afraid of their parents, sometimes you bring, an 18-year-old girl to the clinic with a mother and is unable to be honest with you and may tell you that they've never had sex or had unprotected sex when they have actually done it, out of the fear for the parents. When you come to the Western world, children are very honest to their parents because they're not afraid of their parents, or their guardian. So they will say as it is. And so we try to advise parents to do it as early as possible. And I think there was a group in the Volta region. There was a cohort. There was a pilot study that did it for kids as early as 9.
Yeah. So I wanted to clarify that because I think I said 3 and 4 shots. It's actually the initial study. It was a 2-shot series where you could get one and then 6 months later get the other. And then there's the 3 series where you get the one, then between 1 and 2 months, and then 6 months. And the only risk factor that I would say for people to not get the vaccine is if there's a severe latex allergy or a severe yeast allergy. Interestingly, I haven't had any patients that have had an actual adverse response to it. But yes, the age ranges are 9 through 26, and then in special circumstances, you can extend it all the way to 45. And for males who are wondering why they should get this, I think we spoke to it a little bit earlier, the risk of penile warts, the risk of penile cancer, and the risk of transmission to your partner, even if you don't have any symptoms. Some of the reasons why we want you to get that as well.
Let me just add.
What's the cost in Ghana for the vaccine?
That's quite expensive. Do you know what? It varies. So everyone is stating whatever they want. And that's why I just keep going out saying that we need a program so that we can all have the same price, we have the same program schedule.
Let me add that, here in the United States, the Gardasil vaccine, like you all mentioned, is FDA approved for ages 9 to 45. And it reduces the risk of not just cervical cancer. So HPV is associated with anal cancers, vaginal cancers, penile cancers. So men can get penile cancers and oropharyngeal cancers. So if you think about the changes in sexual practices over the past, 20 years or so, we're seeing an increased number of men with HPV positive cancers in the throat. So this is another very barbaric treatment that I have to do very frequently. And so, if there's a way to get men to buy into it, is also to let them know that it's something that affects everybody, that affects their mothers, their sisters, and themselves. And, if you think about how you treat penile cancer, sometimes it involves surgery and surgerizing the penis. So it's not something to be played with. So if you think about, it's not just something, we always put that burden on women to say, oh, it's a cervical cancer vaccine, but it really isn't. It goes beyond that. And that's why it's approved for both boys and girls, men and women. I got my first vaccine at age 40. Gardasil first came out when I was just turning 27, and I tried to get it, but I was just right past the age limit. But once it got approved, once it got extended to age 45, I went ahead and got the vaccine. I got the first one right alongside my daughters, who were 11 at the time. So, it's not just a cervical cancer thing. I know we're talking about cervical cancer today, but to get our guys also involved, they can also get penile cancers. They can get anal cancers depending on their sexual practices, and certainly oropharyngeal cancers. And I know many good men out there do not want, vaginal cancers or vulvar cancers for their wives, sisters, or family members as well. And the other thing for those of you on the front lines, primary care physicians and gynecologists, it's probably a good idea not to frame vaccinations in, as it's a sexual thing. Before you start having sex, let's go get this vaccine, because that kind of makes parents feel like, oh, so once they get the vaccine, then they're free, So I think, especially in our culture, the way I tell people about it is, this is a vaccine that helps prevent cancer. And when I took my girls to get it, there was no conversation about, we don't even, it's not like, okay, let's do this now before, potentially you become exposed to some, dirty boy or whatever. This is about protecting you from cancer. And I think when parents are brought in that way, they're like, well, let's do this shot. It's a cancer preventing vaccine. And of course, we know the reason we're offering it at this age is to, but I think it changes the dynamic of the conversation if we talk about it in terms of what the vaccine is designed to do and not the timing of it. So I really appreciate you guys for doing all the hard work in the front lines. We get to see the back end of it when things are already out of hand. But I think talking to families and bringing them in is not easy work. So I really applaud you guys who do that.
Thank you so much. So we're going to go into the advice and recommendations from the panel, and what the takeaways should be.
I do have a question.
Yes.
Specifically to Dr. Ichendu, but anyone else can chime in. You mentioned that the HPV virus is ubiquitous, so it's everywhere, and 9 out of 10, I think that's what you said, people have been exposed to it at some point in their lives. And so I get that the vaccination is necessary for boys and girls, but at 40 years, presumably you would have already been exposed to the virus. So what would be the point for the vaccination? For someone that's an adult, I mean, that's basically my point. I assume that, I mean, is it because you could be one of the 10 that, or 1 out of the 10 that was not exposed to it? I mean, what's the point? You probably already have the HPV.
So, you kind of broke off a little bit during your question, but I think I got what you're asking. You're asking why we get the vaccine, even though we are already, most likely already exposed to the virus. So basically, regardless of what we do, viruses will still do what they do. Okay, and this is another thing that I like talking about. I'm a virologist, actually, for those of you who know me. So we cannot prevent virus infection. So infection and disease are two different entities completely. So you can always get infected, but the purpose of the vaccine is to prevent disease. So we can all get infected, we can all get, and we can all get cleared. And the vast majority of us get infected with HPV and clear them. But the difference is when you get a vaccine, it reduces your risk of getting a disease from the infection. Now, we know that many people do clear the infection naturally, but we don't want to take the chance because there's no way of predicting when or who would end up not being able to prevent the disease itself. So, on an unrelated topic, now we're like in coronavirus era. So we're getting vaccine, not because it's going to prevent someone from sneezing on us and putting the virus on us, but the vaccine prevents you from getting or reduces your risk by 95% of getting a disease from the infection, if you understand what I'm saying. Does that make sense?
I do. I'm sorry, I need to come back again. Doesn't the infection stimulate or cause your body to develop whatever soldiers it needs to be able to fight future infection that could cause a disease, and that the vaccine is intended to create that very same scenario.
Right. So I think Dr. Banka may have mentioned it before. There are so many different types of HPV, right? So you might be exposed to type 6. And so, you know, there's no telling if you get exposed to type 18, you know, 5 years later, you know, you don't generate cross-reactivity from type 6 to type 18. But the vaccine actually has all nine, you know, medium or intermediate and high risk types of the virus. And so it helps you develop those soldiers, so to speak, against those high risk forms. So being exposed to one type does not necessarily, you get some protection, but it doesn't necessarily protect you from others. And so that's why we have these non-valent vaccines, so to speak. The first vaccine that came out only had 4 different types of it, and then it's since been updated, I think about 5-6 years ago, to include 9 of them. So if you get a natural infection with one type, that means you're gonna have to spend your life getting natural infections with all the other types of HPV in order to get protected from something you can just get from a little shot.
And can I speak to that a little bit? Another reason why adults might want to still get vaccinated is, you know, we talked a little bit in this forum about women who may not have as much control over their sexual experiences. And so if, especially for women who are not as well protected, if you get unfortunately violated later on, if you already have protection against this, there you go. We also have to deal with the reality that women might move from one relationship to another. And just because you're in a monogamous relationship right now, this is not to preempt anything going on, but this is just reality, that you could be exposed to a separate relationship. So just because you're an adult, just because you're in a monogamous relationship at this moment, does not mean that you should not look to still protect yourself. You cannot control what your partner does as well. Again, reality, I see these things every day. So there is still an argument to be made for still getting protected regardless of your age if you do fall within that criteria.
I just want to add something a little to top up to what you guys have said. I understand where his concerns are coming from, i.e. he's trying to say that if you've already been exposed, then why take the vaccine? We advise that you get tested for HPV before you get the vaccination. I mean, that's the right thing to do. No one is going to jab you with a vaccine without testing you if you are sexually active. So that's just something to throw in there. It's not as if, yes, you've started having sex, you've been exposed, you're high risk, and then somebody just goes in there and jabs you with them. It's like having a hepatitis vaccine. So you're going to get tested for hepatitis before you get vaccinated. That's just, yeah.
And another thing that's emerging now too is I did a medical mission trip to Ghana some years ago, and we did a cervical cancer screening program. And there is some data to show that some of the strains of HPV that are causing cancer in the westernized world might be a little different from the strains in Africa as well. So, I think that's part of the reason why some of these vaccines are expanding their panels as well, just to cover a lot of the different ranges. But absolutely right. My patients who have already been exposed to some of the high risk types, if they ask me about the vaccination, if they've already been exposed to, and remember, there's several different strains of high risk types. I'll focus specifically on the 16, 18, and 45. Let's say they were exposed to 16. Getting the vaccine will still benefit them because it can still protect them against 18 and 45. They don't want to risk being exposed to those other ones on top of the one they've already gotten exposure to. So it does make sense that being exposed already, you're not really preventing that particular strain, but there are other strains that you can still get benefits from the vaccination. I hope that was explanatory.
Very much so. Thank you all.
You're welcome.
So I'm leaving it to the panel to give us your last minute recommendations, and then
It looks like we can go on for like.
it is. So, Dr. Banga, we'll start with you. Give us your last minute recommendations that we should do. Prevent HPV, prevent cervical cancer for our men and women and our youth.
Okay, so my charge to all my women on the panel: don't neglect yourselves. Remember, we are nurturers at heart, but we have to take care of ourselves to be able to take care of the loved ones in our lives. And to all the men on the panel, encourage the women in your lives, your mothers, your sisters, your daughters, to get screened as well so they can protect themselves. And make sure you take care of yourselves as well, because prevention is better than cure, as we've heard through this panel. So if we can do a lot in the beginning to try to prevent exposure by vaccines or by catching the disease early on in the preemptive phases, then we know that we can recover so much better and have a better quality of life. So don't treat your physicians as your enemies. See us when you need to, and take care of yourselves. That's my final word.
Thank you. Dr. Prampe, you can go next.
So my little statement is that tell a friend to tell a friend about cervical cancer. And in as much as there's systems and programs in place in America or the US, there are Nigerians and Ghanaians and Africans in the US and UK who are not willing to get screened or get vaccinated or get their kids to be vaccinated because of the cultural barriers that we've brought from wherever we're coming from. And so please tell a friend to tell a friend, tell a sister to tell a sister. And so we can all live as long as we are supposed to and not get killed by cervical cancer and any other form of cancers.
Dr. Cheezer, you're up.
This is something I, say to myself and my family and my patients, is to always advocate for yourself. Knowledge is power. The reason we have these forums is to inform and to get feedback from you and share what we know. And so with what you've learned, use that to advocate for yourself, and also just to erase the stigma associated with cancer, erase the stigma of even the symptoms that go with cervical cancer. If you have abnormal vaginal discharge, you're not the first person, you're not, in isolation. If you have vaginal bleeding, pelvic pain, you did not do something sinful or something wrong. Do not let societal stigmas, do not let religious stigmas to blind you or to impede you from getting the help that you need. Vaginal discharge, foul smelling or not, bloody discharge, whatever it is, pelvic pain, bone pain, don't ignore anything that's different. So if you notice anything different, just seek medical help. And I know that it can be challenging getting access to good medical care in some of our communities. So I think this is why this platform is available. And if there are resources that we can offer to help guide or to help navigate some of the healthcare concerns that you have, I'm sure we'll be very happy to do that. So seek assistance and advocate for yourself. Remove the stigma from cervical cancer or any kind of cancer. And that's all I have to say.
Thank you so much, Dr.
Again, thank you all for joining us. I think my colleagues have said it all, but the little that I want to add to is, your physician is your friend. None of us are your enemies. So feel free to talk to your physician. If you're experiencing any symptoms that is unusual, talk to your physician, especially back home, in which we believe in traditionalists and herbalists and all these other self-acclaimed doctors that are not physicians. Instead of going to them, I would recommend you talk to your physician about your problem. It is not okay for you to be having pain having sex. It's not okay for you to be bleeding having sex. It means that there's something wrong. Discharges, it may be benign, but it can also denote something serious. So talk to your physician, find a physician and talk to your physician about your problems. We have our platform too. You can reach out to us. You can reach out to us, Cancer Support Network of Ghana. I think last year and a year ago, we actually supported some people to get screening for cervical cancer, like, mass screening, in which we paid for it. The donations that we get from our viewers and people, like, that donate to us, we use that to support some women to get screening. So if you really are having symptoms or, like, anything unusual, you can always reach out to us through our website or our Facebook platform. And we have some people like Dr. Prempe that we can let you go and see so that things can be taken care of. So don't hide anything. We are all women. We look out for each other. And as Dr. Ichendu said, take care of yourself. Be your own advocate and advocate for the women in your family, the women in your circle, your friends. Talk to them about it. What you have heard here today, make sure you're talking to people about what you heard, what you learned. That's how we get the information out there to prevent, cervical cancer. So that's all I have to say.
Thank you so much. Today has been awesome. Thank you so much, Dr. Chiza, Dr. Banga, Dr. Prempa, Dr. Pierre. Thank you for helping me man the chat as well and answering the questions, because I am multitasking and I see that we're having a coordinated effort here and it's really good. I'm really glad that we are able to share this information with the people that are on the panel. We put our website on the chat, so please, that's the link to go to the website. If you have a question, please bring it down our way so that we can be able to direct you to where you need care or find answers for you if we don't know. Every month, like this is, cervical cancer month, we collect donations and we use that money to support whether screening or people who are receiving treatment in Kolibos. So please go to our website and make any donations that you can so that we can use this as a way to help people that need screening or people that need treatment and have difficulty paying for it or difficulty being able to stay in treatment. We are thankful to everybody that took the time to join us. We have gone past the hour, almost 2 hours, and people really were patient to stay back and to really listen. And so as we have over 59 people, let that tell somebody else. And as Dr. Premper said, tell a sister, let a sister tell a sister, or tell a friend. So let's share this information, let's send it out, and so that we can be able to reach as many people as possible. Somebody did mention the chat, is a program in Ghana, is a government program. Part of all of this that we do is what sends the word out. And what would get to our our elected officials and to get that information that this is needed in our communities. And so I'm really thankful that we had a great session today. Thank you. And if you're in Ghana, have a good evening. If you're in the States, have a good afternoon. Thank you so much.
Thank you, everybody. Oh, so our next discussion will be on colon cancer in March. March is Colon Cancer Awareness Month, so we'll try to put a panel together to discuss screening, diagnosis, treatment, and management in general. So if you're available, you can join us. But thank you, speakers. I really, really appreciate you all. I know you're very busy, Dr. Banga, Dr. Ichendu, and Dr. Prempe. Thank you for taking the time to educate our women and our men. I really, really appreciate that. God bless you all. Good night and good afternoon. Bye, everybody.